Hi, I am presenting my week 2 musculoskeletal SOAP note. So, yesterday in the clinic, I saw patient AE, a 78-year-old white non Hispanic female who presented to the clinic with a chief complaint of I have pain in my right wrist and I would like to get it checked out before it gets any worse. She said that she's had this pain for 2 weeks. It's in her right wrist. She said that her symptoms have increased over the last 5 days, and that's why she's come in today. She said the pain is right here in this dorsal ulnar aspect of the right wrist and it radiates into the mid forearm. She said it's a constant dull ache and has intermittent episodes of sharp pain with activity and movement. She said her pain is between a 2 and a 5 out of 10 and her current pain is at a 3. She said over the last 4 weeks, she has had an increase in her gardening activity since the weather's gotten nicer. And she is also a primary caregiver for her 98-year-old mother. And when asked for more information about that, she said she lifts, she grips, she's really doing most ADLs for her mother. So she has a lot of repetitive movements. She said when she uses it or moves her wrist, it makes it feel worse. She has tried 600 milligrams of ibuprofen every 6 hours, icing and massaging, and she says she hasn't had a lot of relief. She denied any history of injuries, trauma, falls, illnesses, or fevers. She does have a past medical history of osteoarthritis and osteopenia. She currently takes a daily calcium and vitamin D supplement and then ibuprofen as needed for the pain. She has had a total knee replacement in 2016 for osteoarthritis. Doing a review of systems, everything was otherwise negative except for that right wrist pain. When asked specifically if she noticed any swelling, redness, or warmth to the area, she denied that. She also said she hasn't had any numbness, tingling, weakness, clicking, popping, or instability. Her vital signs are stable. Blood pressure is 124/80, pulse is 76, respiratory rate was 16, temperature was afebrile at 97.2, and her BMI is a little high at 26.2, putting her in the overweight category. On her physical exam, she appeared well and in no acute distress. So this examination of her right wrist revealed that she has some tenderness to palpation over the dorsal ulnar aspect of the wrist, but there was no swelling, no obvious deformity. I did not feel any warmth. There was no redness or erythema noted, no crepitus with any testing or movement. Her range of motion was limited and painful with flexion, ulnar deviation, and supination, and then she has full range of motion with radial deviation and pronation. Her grip strength was strong and equal bilaterally, and I didn't notice any clicking or instability noted on the examination. I did a quick sensation test with just some soft touch, and she was found to have just intact sensation. She has bilateral radial pulses are +3, they're strong, and then her capillary refill in the upper extremities is less than 3 seconds and brisk. I did some special testing. So I did an ECU synergy test, which is the extensor carpi ulnaris synergy test. And then I also did the ECU subluxation or ice cream scoop test. So both of these tests came back positive. The ECU synergy test, she didn't have any bowing of the tendon, but she did have pain. And then the ECU subluxation, she didn't have any tendon snapping, but she again did have pain. Because of her age, her history of osteopenia, the worsening pain, it was prudent to order a 3-view x-ray. When we reviewed that x-ray, we saw that there was no fracture in the wrist and there was no evidence of osteoarthritis within the joint. So that kind of helped rule some of my differentials down. But my differential diagnosis included the extensor carpi ulnaris or ECU tendinopathy, triangular fibrocartilage complex tear or TFCC tear, a distal ulnar fracture, and then osteoarthritis of the wrist. I was able to rule out the osteoarthritis of the wrist really just given the patient's presentation of this acute onset of pain, no morning stiffness, things like that. It just didn't match the osteoarthritis presentation. And then the distal ulna fracture, she hadn't had any trauma or any injury that would lead me to believe that she would have a fracture, but because of her history, I just wanted to make sure we were evaluating for that and ruling it out. And so I was able to rule that out with the x-ray. So my primary diagnosis is the extensor carpi ulnaris tendinopathy, and I felt like that was appropriate because it commonly occurs following repetitive movements or activities, and it presents with this dorsal ulna wrist pain that gets worse with activity. So I picked this diagnosis because my patient was reporting this increase in repetitive wrist activity through her gardening and her caregiving responsibilities. And then her pain was located on that dorsal ulnar wrist. It worsens with use. And then I was able to reproduce that pain when I did the ECU testing. So I felt like those findings really strongly supported that diagnosis, or as the most likely diagnosis. My second diagnosis was that TFCC tear. So the TFCC is that cartilage structure that is on the ulnar side of the wrist. It kind of acts like a stabilization or a shock absorber for the distal radial ulnar joint. So when you have a tear, it often presents with ulnar-sided wrist pain, especially when you're gripping or doing rotational movements. I did consider it because of the patient's pain location and then the activities-related symptoms. But because she denied any trauma, falls, no clicking, no popping, she didn't have any grip weakness or feelings of instability, I felt like it was okay to sort of rule this out. However, this can't be completely ruled out without an MRI. So these can commonly co-occur with the ECU tendinopathy. So I think it's important to consider this. So going through my treatment includes conservative management with activity modification, the RICE method, rest, ice, compress, and elevate, and then immobilization using an ulnar gutter splint, which we put on. The patient was instructed to use acetaminophen, 650 milligrams every 4 to 6 hours as needed for pain, and then ibuprofen, 600 milligrams every 8 hours. And I educated her on those maximum daily doses and the importance of if you don't need it, don't take it. So she was also referred to physical therapy for an evaluation and treatment. And then an MRI was ordered to evaluate for that possible TFCC pathology. And if the symptoms persist, an orthopedic referral will be placed if there's no improvement after about 8 weeks of conservative treatment, or if that MRI comes back positive for a tear. So I did include some education for medication safety, the recognition of adverse effects with NSAID use and activity modification, and then avoiding repetitive activities and weight-bearing activities. I'd like her to follow up in 2 to 4 weeks for reassessment, and then she can return sooner for worsening pain, numbness, tingling, weakness, or loss of function, and ER for black or bloody stools, chest pain, shortness of breath, or difficulty breathing.